Good morning, ladies and gentlemen, and welcome to the SAIEE Biomedical Chapter launch. Before we start, a few webinar considerations. Attendees are reminded to ensure the volume is turned up on your device. Ensure you have a stable internet connection. This will ensure the streaming and audio will run smoothly. Attendees can ask questions via the questions panel located within the GoToWebinar control panel. By default, the control panel is located on the right-hand side of your screen. The chat function is reserved for webinar organizers and panelists to communicate with attendees. Attendees will not be able to chat with each other, however, are encouraged to ask questions. A recording of this webinar will be made available on the SAIEE YouTube channel, SAIEE TV, under the Biomedical Chapter playlist. This channel is updated regularly, so please find the registration link in the chat box and register to receive notifications. Registration is free. A certificate of attendance will be issued a few days after this webinar. I'd just like to bring to your attention that we will be running a poll at the end of this webinar, just to see how you've learned about this webinar, just so we can sharpen our pencils with SAIE's communication channels. I'd like to introduce you now this morning to our host, Prof Pat Naidu. He is visiting scholar in the Department of Mechanical Engineering Science and Professor of Practice in the Faculty of Engineering at the Built Environment, University of Johannesburg. He's a Fellow of the South African Academy of Engineers, a Fellow of the South African Institute of Electrical Engineers, a Senior Member of IEEE USA, a Member of IET UK, and SEAGRAE France. He is a Registered Professional Engineer and a Specialist Consultant in Electrical Engineering, Electrical Energy, and Power Systems. And I might just would like to add, he's also a past President of the SAIEE. Over to you, Pat.
Thank you, Minx. Thank you. Good morning. On behalf of the President and Council of the Institute, welcome to the launch webinar for the South African Institute of Electrical Engineering's Biomedical Engineering Chapter. And this chapter that is positioned to bring together the faculties of medicine, faculties of engineering in the pursuit of healthcare and a better quality of life for all. The fourth industrial revolution is opening new doors to managing healthcare as in data, information, and intelligence, involving Internet of Things, machine learning, artificial intelligence. So a lot of the machines are going to go forward and assist us as we contribute to the quality of life of society. All are welcome to join the chapter and to participate in the workings of the chapter, and we welcome your participation at the webinar today. Let me introduce the incoming chairman. Council has recommended that we invite Dr. Pradish Rampersadh, who's the head of research at NECSA, to come forward and to lead us and constitute the chapter going forward. Over to Dr. Pradish Rampersadh. Thank you.
Sorry about that. Thank you, Professor. It's such a pleasure and an honor to be here today to engage with the colleagues, of course, today. I hope that I'm able to provide some guidance and use our networks within the Nuclear Energy Corporation of South Africa to create opportunities for our engineers and our scientists to collaborate and build the biomedical chapter of the SAIEE. And it'll be such a pleasure to engage and chat to all of you. I just want to quickly, if you don't mind, I would like to take a few moments to do a presentation to talk to you about NECSA, what we do at NECSA, some of the work that goes on, and hopefully with that allow you the opportunity to see the areas where we can collaborate. So very quickly, Minx, is my screen showing?
I see your blue desktop with IT call logging process. So you just have to swap displays if you have two screens.
Okay, let me just quickly do that. Give me a second. And I will have to, let me just quickly share that. And one of the dangers of two screens is that it tends to do that.
Presentation mode now?
Okay, let me just quickly get this in presentation mode. And of course, my luck, it jumps to the other screen. My apologies. Apologies. Let me just do it this way rather. Let me rather do it this way, is that I will just, yeah. Is that visible to everyone now?
Yes, that's good.
Excellent. I'm sorry about that, the technology challenges sometimes we are faced with. Yes, so of course, very quickly, the South African Nuclear Energy Corporation, NECSA as it's known, is a state entity. It's owned and controlled by the state. And it's important that we appreciate what it means to be a state entity, is that it's accessible to the scientific and engineering community out there. This is created to serve South Africa. It's created as a research organization to serve South Africa. There are numerous areas of research that we're involved in, but of course I will focus specifically on the area of medical isotopes. I think it's important, before I unpack a little bit about that, to show you the structure of the organization, that we actually, as NECSA, which is the state-owned entity responsible for promoting research and development in the field of nuclear energy and radiation sciences, it's important to note that one of our assets is the Safari 1 nuclear reactor, and that reactor, being although almost 60-odd years old, is actually recognized by the IAEA as being one of the best performing reactors in the world. We actually operate this reactor for 300 days a year, and that being the case, we utilize this reactor, of course, for some material development. We use it for medical isotope production, and of course, the idea of beamline analysis of samples on behalf of the state and on behalf of the academic institutions in South Africa. From that, we actually have been able to spin off two companies. One is, of course, Palchem, Palchem SOC, and Palchem being a specialist chemical company. So we supply hydrogen fluoride and fluorine into the world market. One of our specialist products is xenon difluoride, which is used in the electronics industry. And we pride ourselves as being one of the suppliers with the purest product basically on the market, or close to the purest product on the market. The other product, the other company, of course, is NTP Radioisotopes, and this is a leading global producer and supplier of nuclear medicines and radiation-based products and services, which I'll unpack in a few moments for you all. And what's important about this company is that last year we actually were regarded, I think, as basically #1 and #2 in the world in terms of supplying these products, and but we are definitely among the top 4 overall in the world. What we find very nice about NTP radioisotopes is there's a growing demand in this space. There's a growing demand for new products, and that has resulted in the spin-off of us actually creating a whole research division within NECSA that actually manages this. Now, this is a little bit about NECSA, a little bit about, especially what's important was in 1965 was the Safari 1 reactor's first criticality. Of course, you know, there was some history with NECSA with regard to the creation of the Atomic Energy Board in those days. We actually had a full enrichment facility on site, and we actually manufactured nuclear fuel for Coburg. But of course, economics of scale do tend to work against you, and that resulted in us eventually shutting this down and moving the Nuclear Energy Corporation more towards commercial type work, which is of course where we found ourselves able to survive as an entity. And of course, the organization, I'm not going to go too much into the slide, but you would find that specifically the product focus is towards the chemicals and of course towards the radioisotopes. Now, with regard to the radioisotopes, I think it's important that we take a moment to look at what exactly does NECSA do here. And NECSA, of course, does produce active pharmaceutical ingredients. And within these ingredients, we look at molybdenum-99, of course, which is what we are one of the biggest suppliers in the world with that. That's mostly used for prostate cancer diagnostics. Of course, there's iodine-131, lutetium-177. We also manufacture therapeutic radiopharmaceuticals, the capsules of iodine-131 for thyroid cancer and metastatic diseases, lutetium-177 for prostate cancer and neuroendocrine cancer. We do provide radioisotopes also to the industrial, iridium-192, cesium-137, and we also provide diagnostic radiopharmaceuticals, Novatech. These are generators whereby these radiopharmaceuticals that are used in the pharmaceutical industry is actually generated in situ in this in these kits that we supply, and that allows the medical practitioners to then, of course, distribute this to their patients. Now, moving forward from a NECSA perspective, this is just the tip of the iceberg in terms of development of radioisotopes. Of course, there's a lot of additional work going on at NECSA, and I think just to touch on a few things, we would look at there are several theranostic radiopharmaceuticals that are now hitting the market, and that being the case, various stages of drug development is currently going on at NECSA. And what's important about that, we actually are working very closely with a lot of hospitals. We're working very closely with the Numerai facility. This is a DSI initiative at Steve Biko Hospital, and we actually initially housed it at NECSA, and of course now it is one of the leading developing areas in terms of obviously doing therapy work in terms of radiopharmaceuticals. So it's spun off from us, and I think that shows a great opportunity, especially in terms of the radiopharmaceutical world. We're looking at gallium-68 PSMA kits, prostate-specific membrane antigen kits, and of course rhenium-188 skin cancer. And just to talk a little bit about some of the work that we do at NECSA, of course, we do radiolabeling of drugs that lead for screening, new radiopharmaceuticals as precursor for radiopharmaceuticals, tracing of carbon-14 labeled molecules. Also, we do some preclinical imaging. We work, of course, with hospitals and wherever we have to engage with preclinical imaging of radiolabeled compounds. One of the areas we're looking at is a product called GlueCap, which is a radiopharmaceutical, which is also being developed as a theranostic drug. Of course, we do have to have full compliance with legislation. We look at regulatory compliance registration, of course, the SABC being one of them. Of course, good manufacturing practice. This is medical isotopes. So good manufacturing practice means we have to follow the rules of or what's required by the pharmaceutical industry. So of course, we do manufacture small batches for human studies at hospitals, and of course, compliance with the health regulator. And of course, we use the gallium-68 PSMA kits for prostate cancer imaging. So this is a little bit about it. Of course, as you can see, there's the product that we manufacture, and of course, it is injected into a patient, and of course, we image the patient to see if there is a detection of cancer. So some of the other areas we're looking at, rhenium-188 skin cancer treatment. Some of the initial work done here, work by Professor Mike Sateke, of course, has been very positive. We've actually seen some really brilliant results, and of course, this is a new products that we are developing. And I think what is important for us as NECSA is that as an organization, in terms of medical work, medical isotope work, there's a whole world available to you here as the engineering and scientific community to engage with NECSA, to get involved in this research. The more we develop, the more we benefit. This is, as I say, is a state-owned entity. So of course, the comeback from this is fed back into the state to assist our patients and to assist South Africa. So we actually, as NECSA, are more than willing to engage with key partners in nuclear and related industries. Thank you so much.
Thank you, Dr. Rampersadh. Thank you very much. Colleagues, we now introduce to you Professor Vangu, our keynote speaker. Over to Minx.
Prof Vangu, did you receive the prompt?
Minx, would you kindly introduce Professor Vangu, his profile?
I have it now.
Thank you.
I will do. Prof Vangu, just
Can
put
you
your
see my
presentation.
screen now?
Yes, just put it in presentation mode.
Is it ready?
Yes, perfect. Can I just introduce can I just introduce you, ladies and gentlemen? Prof Vangu is a chief specialist in head nuclear medicine at Wits. For the CM Johannesburg Academic and CH Baragwanath Academic Hospitals. He's also the head of the Department for Radiation Sciences at the University of the Witwatersrand. His academic qualifications are as follows: MD, MMED, MSc, PhD, and he has numerous publications, conferences, and workshop proceedings, as well as keynote addresses locally and internationally. He's also received an executive MBA from the University of Nebraska in the USA and a certificate on fundamentals of clinical and translational research with the Harvard Catalyst Educational Program in the USA. Over to you, Prof Vangu.
Thank you, Mings. I hope you're seeing my screen nicely.
Yes, we do. Thank you.
All right. So good morning, colleagues, and thank you for the opportunity to be in this meeting this morning. So when Professor Pat Naidu actually approached me to provide a keynote speech for this launching of this through this webinar, you know, immediately, spontaneously, without even thinking, I say, yes, I will do that. But to be honest, later on, I started to regret because I started wondering, I say, modern health, a nuclear medicine physician will be talking to a bunch of engineers. But to my rescue was the word that were clear in the webinar title saying that the biomedical engineering. So I said to myself, well, so at least for the part of biomedical of them, if I can combine some or anything that is medical with kind of manipulation of numbers, it will do the trick. So I said, why not to select something like PET-CT technology in nuclear medicine? Because it is a technology that I consider to be conceived with empathy. As if I have to ask you to look at the word, the meaning of the word empathy, you will realize that there are of three kinds: the cognitive, emotional, and compassionate empathy. So the last one, the compassionate empathy, actually fits well with the PET-CT technology, simply because empathy or compassionate empathy means understanding a person's predicament and feeling with them, but spontaneously move to help if needed. And PET-CT actually is the prototype of compassionate empathy in the real world. With the evolving technology that we use today, it's going so fast. I believe that compassion should be at the center of anything. Technology today without compassion means nothing. And PET-CT with compassion participates on providing cost-effective and efficient care to our patients. Actually, it's a modality today. Even the stingy economist will agree to say that this is a value for money. So now I want to change my slides. Mings, it's not changing.
So you can just click on your presentation again, because you would probably have the control panel, and you just use the right arrow.
I see it there. All right. So to do justice to the ascension of talking about technology with empathy, in the next few minutes, what I'm going to do, first, I'm going to take you back to a small background on the technology, PET-CT itself, where it comes from, and then I will focus on only one selected application so that I give you a bit of a test on the use of PET technology in clinical practice, and then I will close with my perception on the future of this technology. So let's start. To begin with, I know that PET-CT to you may sound like or may seem like a foggy concept. And then I will try during this presentation to clear some of the fog so that it can become something clear to you, even though it's not going to be completely clear, but at least in the few minutes you can understand what PET-CT does. So first, the development of PET-CT actually comes from the genius creativity of scientists from many disciplines, as you can see there. So although many contributed, but credit to me, it's always to be given to two pioneers that I always think that they have to be recognized. The first one is Paul Dirac, a theoretical physicist who actually published on the existence of positive electron based on the equation of quantum mechanics and the theory of relativity of Albert Einstein. But it was in September 1932 that his prediction was proven to be correct by another physicist, David Carl Anderson, an experimental physicist who actually observed that cosmic rays, actually they had a mass of an electron and they travel in a path with a strong magnetic field that show the positive charge. We call them positron or positive electron. In fact, today, the basic principle of PET-CT is rooted in the presence of having a positron due to the annihilation, and then the signal or photon that they emit can be captured by cylindric detectors. So to put it in a simple term and explain to you easily, an individual is injected, as you can see on top left there, with an isotope that the previous speaker here, they say they produce locally here in NECSA. And this isotope will then emit photon in annihilation, as you can see there, in 180 opposite degree the direction. And this photon will be captured by a cylindric detector, and then an image is produced. Simple as that. The first PET-CT was produced by the group of Ter Pogoshan at the Washington University in St. Louis, Missouri. In your left, you can see Ter Pogoshan himself in his lab, and in the right side, you have the original PET-CT as it looks back then. It looks a bit monstrous, but this was the beginning of the PET-CT. However, something significant happened in 1976 and changed the whole use of PET-CT and revolutionized actually PET-CT technology. It was the production, the first production of an analog of sugar called fluorodeoxyglucose or FDG that actually changed everything. And I'm going to spare you about the chemical structure detail of this and how it works, but if there is a question, then I will go through and explain to you how it works. But this molecule actually changed everything, and then it was the beginning of the renaissance of PET-CT imaging. And despite, like Pradish can tell you today, we have other molecules that they produce for PET imaging. Many are today specific, like you heard was talking about the gallium, the PSMA for prostate, and then we have others also specific for other entity. The FDG today remains the bread and butter of PET-CT imaging in nuclear medicine. In 2001, then PET-CT technology took a different turn, and this turn was actually significant because for the first time, David Townsend and Ronald Nutt actually launched a PET-CT machine. Before we were using only a PET technology. So what happened is that for the first time you have one system having two components, one side having a PET, on another side having a CT. And then the image that are produced by both of them are fused or combined together, as you can see in your right-hand side, and beautiful images that's gonna give you both the anatomy and physiology of what's happening in the human body. This is what actually some of imaging specialists been calling the perfect wedding of images. The PET technology continued to advance with the digital technique that was introduced 15 years later. And in November 2018, the first world total body PET-CT was launched. And the physics journal of the World Journal of Physics named it as the breakthrough of the year. And they were completely right, because this beast, as you can see it there on the top, they can reduce the imaging time 40-fold compared to the usual analog system. Here you have an image of a whole body from head to toe, and this was acquired just in about a minute. You can see how the throughput can be actually increased in a busy practice where you have a lot of patients waiting. If you have something like that, you can do as many cases that you want in a day, and then we'll cut all the so-called waiting time and waiting list. Right, so now, like I said, that I'm going to use one selected item on the clinical use of this machine. To talk about the clinical practices of application of PET-CT, there are so many that if we have to talk about them, we'll take the full workshop, but we're still not going to be able to finish them. So here, what I'm going to do, I'll select just one angle of infectious disease so that I can give you a bit of a taste of how PET-CT can be used in the clinical practice. I selected infection simply because I see recently we all were a victim or experience actually what infection can do to many of the human activity in the society. You've seen how COVID-19 paralyzed the whole world and put the world to a kind of stop that Stuart Pince actually called the global pause. So we experience it. So what I'm going to do, I'll select just one angle of infection, one of the infections that you know very well, you grew up learning about it and you see its effect in the society. So I will look at the role of PET-CT in tuberculosis. Today, most of the PET-CT done in tuberculosis are mainly for evaluation of response to treatment. And sometimes you can also use it to look at other areas of the disease that are not in the lungs, such as the tuberculosis that affect the bones or going to other lymph nodes. But I personally believe that what we need to use it today in medicine is in tuberculosis, we have to do it in a way that we can actually predict outcomes of what we're doing with PET imaging in tuberculosis. So I'm going to focus in a few of the work that we've done ourselves so that you can see the prognostic role of PET-CT. But before I do that, I want just to remind you that you have to understand or take note that in our environment, HIV actually it will put somebody at risk of contracting tuberculosis. And in environment, we know that about 1 out of 10 cases of tuberculosis will also have HIV. And then 1 out of 5 deaths related to tuberculosis will be also having underlying HIV. The second thing that you have to know that is today the HIV treatment, the new treatment, has dramatically changed the HIV disease landscape. Individuals with HIV treated with the new ARV treatment showed better improvement and there is improved survival. But if at the same time they also have tuberculosis, this treatment that is becoming a very good treatment for HIV, if it is together with tuberculosis, may trigger an inflammatory syndrome that is known as IRIS, which is a syndrome that's going to put the lung into risk of being damaged. But because there's been very little data or knowledge of how this inflammatory syndrome happened, that somebody with tuberculosis and HIV, when starts this new drug that is showing good outcome in HIV, they get even sicker, particularly for their lungs. So what's happening? So what we've done, we decided to test the hypothesis that a robust treatment of HIV in an individual having also tuberculosis actually will cause damage to the lungs. So what we've done using of glucose, this molecule that I said UFDG, that is an analog. And for example, look at in the area of C or the area that you're seeing very whitish there, it's the area involved. And then what we found that this increased glucose in the area affected with TB correlated directly with impairment of lung function. So what I'm telling you can be translated simply with this image that you see here. If you look at the top row of the three screenshots that we selected from three different patients, on the image on the top, before they start the new HIV treatment, the ART, you can see the amount of tuberculosis activities there. It's small. But once they start the treatment, by 4 weeks only, in the bottom row, as you can see, the expansion, that light that you're seeing there, the whitish you're seeing there, for each one, from this to this, from that one to this, and from the barely seen there to this, it tells you how there is a fire inside the lung 4 weeks only after starting HIV ART treatment. And the detail of this, we publish it in this paper if it's of interest for you. Then we decided to go further to say that these changes that we see in the lung there and that are expanded when you use the HIV treatment is really due to tuberculosis or not. So what we've done, we'll look at the correlation of these changes with the immunological factors and markers that we stimulated them with PPD. PPD is a test that you use to diagnose TB. And we found there was a straight direct correlation with all the immunological markers. And then I'm not going to give you all the names that can actually give you some dizziness. You can see all of them there. Some of them I can mention, like the tumor necrosis factor alpha or the interferon gamma, interleukin 2, but I'm not going to name all of them. And then the circle plot that you're seeing here definitely then demonstrated and confirmed what we saw there was real. If you look at the half of upper of this circle, it's each and every individual patient that participated in the study. And then in the bottom half lower, it's all the changes that happen as they participated and then 4 weeks after initiation. So here as well, I cannot go and start telling you each and every block, as you can see there, even though they look like somebody is in the screen trying to book a seat in the amphitheater, but this is the true result of what's happening in science. And then we publish all of them also in this paper, if it's interest to you to see and understand what's going on there. Now that we're sure, and that are sure to say that actually the HIV treatment trigger this inflammatory syndrome, what can we do for as a next step? And the next step is will be only to see, is there any way that we can make sure that they develop a treatment that's well given together to avoid the lung that's taking an HIV treatment with TB not to fire up and then have this inflammation. But to do so, you have to know in the whole inflammatory cascade where the starting point is. So we went and looked at the pathway of inflammasomes, which are small particles that can really induce inflammation. And then we found a strong correlation between the glucose that was increased and retained in the lung with the PET scanner using FDG with a inflammasome NLCR4. To put it in the layman language, the simple term is, if you decide to go to any of the one of the room in your house that is completely dark, you want to go and collect something, it's simple. You arrive in the door, you just switch the light on, and then you know what I'm going to collect, and then it's easy. But if somebody were to disconnect the switch, you come at night, the room is dark, you put the switch on, it's still dark. It's going to be very difficult for you to find what you want to do. So this is the same principle that we would love to use, so that if we can switch off this NRC inflammasome, and then when you start the HIV treatment, you're not going to flare up the lungs anymore. So this is the principle of the so-called host-directed therapy that is taking place now in many studies, and then we're doing one. So, and this finding also were published in another paper that you can look at it if you are interested. I hope that with these few slides and what I said, some of the fog that were there at the beginning has been clear. So to go to the last part of my presentation, I want to go and look at the elements that usually will increase the accuracy of this imaging modality that we do and we use. And first, let's look at quantification. It's one of the unique features of PET-CT technology is its ability to go and look at individual counts as we inject the radiopharmaceutical that we're going to image in the patient. The PET technology can look at it at individual that will increase accuracy and reproducibility. And lastly, Rogash et al. Actually provided us with a complex combination of processes that one should use if you want to do quantification in nuclear medicine, and particularly in PET. The headache or the thorn of this is that you have to be very careful and be able to know which one of these so many quantitative parameters that can come from the PET-CT will be clinically relevant. Because at the end of the day, anything that we do in the medicine should be actually relevant to the patient and relevant to the cost, the economy, the health, everything. So it's good to just use research for research, but if you have so many, which one actually will be meaningful in the clinical practice? This is the headache. To tell you that ourselves, we've been looking at quantification or quantitative modeling for quite a number of years now. We started actually earlier in 2014 that resulted in the PhD of Professor Francis Harsford. And more recently, we look at also in other way of looking at innovative quantitative way on the PET when you're doing tuberculosis. Now, I'm going to end with what has become the most attractive, if not sexy, acronym in everybody's mouth today, AI. Everybody talks about AI. In the nuclear medicine, you have so many possible applications, as you can see the list in front of you. But I highlight slightly the two of the area that are currently most used in nuclear medicine. And in PET imaging, AI is mainly used or directed toward the development of processing algorithm using machine learning. And the main reason that we do it, we try to improve, because we work with imaging, to improve the signal to noise ratio. And then what we do, anybody knows that, using all these neural networks. So we do multiple layer using raw data so that we can decode them and then improve the noise. In our own environment, we decided to take an hypothesis that if we were to reduce the amount of the dose of radiation from FDG that we give on our patients routinely every day, if we reduce it and we reconstruct the acquired images with a machine learning algorithm, an assisted AI that's called deep learning reconstruction, we presume that we're going to have images of same quality than if you had to give the full dose. So this prospective trial was done in 2 phases. A week before we give a full dose in a routine way. A week later, the participant return and we reduce the dose to a third. And we then reconstruct both of them using the routine OSEM and using different matrices and using the AI. What we realize that actually the deep learning reconstruction improved the quality of images. As you can see here, as a result of the phase 1, into your left, the top row of images is with a full dose using the usual reconstruction, and in the bottom row, a third of those using the AI reconstruction. And these bottom row images, as you compare to the top and third, looks similar, if better. And then even the data themselves into your right, you can see in the top violin plots and the bottom scatter plots showing you that they're equal, if not better. And the phase 2 that's we just finished to validate what we saw in the phase 1 actually confirm exactly that if you use a third of a dose and reconstruct the images with this deep learning algorithm, you're going to have images of a similar quality like if you give a full dose, if not even better. So I finish here, and I hope that I clear most of the folk that were there, and I cannot wait to see the biomedical engineering coming and collaborating with us, particularly on quantitation, on many other AI applications, so that we can see good results. Although I presented this information and in the language that is not really your routine biomedical engineering jargon, I still believe that it sounded to you in the same way that music was to Wolfgang Amadeus Mozart, who in a letter to his father on the 26th of September 1781 said, quote, "Music should not be painful to the ear. It should flatter and charm it," unquote. I'll stop here and I thank you for your attention.
Thank you, Professor Vangu, first class. And we'll get the AI specialist to come forward and to work with yourselves as we gather momentum on the chapter itself. Well done. Thank you, sir. Next we have with us is Dr. Mavunda, also going to deliver to us a keynote address. Over to you, Minx, to introduce Dr. Mavunda and proceed.
Thank you. Thank you, Pat. Dr. Risimati Mavunda, Senior Research Associate from the University of Johannesburg. He obtained his PhD in physics from the University of the Witwatersrand in 2008. His areas of specialities are nuclear physics, radiation physics, experimental physics, and environmental physics. He also obtained his MSc Med in nuclear medicine in 1996 from the University of Witwatersrand. Dr. Mavunda worked at different institutions such as NECSA as a radiation specialist and UJ as a research associate, and he is currently the UJ Radiation Protection Officer. I would hand over to you, Dr. Mavunda. You will be getting your prompt now.
Thank you for inviting me to give a presentation. My area of talk today, I would like to talk about the processes involved in terms of the type of radiation sources and the equipment that are required for nuclear medicine in order for imaging, as Professor Vangu has alluded, to show how these things are done.
You, Dr. Mavunda, please put on your webcam. We can see you. Thank you. And then go to slideshow.
Yeah. Sorry, Pat.
Slideshow mode. Thank you. Slowly, do it slowly. Perfect. And if you go to slideshow mode, thank you. Thank you.
Okay. What I was saying is I would like to present the processes that is involved in terms of nuclear medicine, how the sources are used in order for one to get an image, as Professor Vangu indicated. So if you look at the bioengineering, it's a multidiscipline field. One of the components which is part of nuclear medicine. As you can see now, it covers quite a wide range, starting from machine learning, design of equipments, radioactive production, until you get also the substances into the human body. So if you look at the bioengineering in the medical field, biomedical engineering plays an important role in research, design, and all these other things in terms of maintenance of all different types of equipment used in medical field. And if you think in terms of the hospital, you would think about all type of equipment which are designed for medical application. A simple example, if you look at patient beds, thermometers, ECG, all of those is based on this biomedical engineering. And medical gloves, all those are part of the biomedical engineering. So when you look at these areas where this biomedical engineering university in South Africa, you'll find that you get the Rhodes University, West University, Cape Peninsula, Vaal Technology of University of Technology, Stellenbosch, University of Pretoria, University of Johannesburg, which focuses specifically on the medical sciences from the Faculty of Health Sciences. So if you check on the top universities that covers this, it's University of Witwatersrand, Vaal University of Technology, Stellenbosch University, University of Cape Town. Those are the major universities where this kind of engineering can be conducted. So now come to what kind of people who are trained as specialists in this area are biomedical physicists, Their functions to conduct research and experiment to undertake to understand the physics and the chemistry of the biological system. Because if one doesn't have this understanding of this, you would not be able to solve the problem that the medical problem that people has, and analyze the data generated from their experimental using statistical method and computational modeling, as you have heard already from Professor Vangu. Develop a new technology and technique to study biological system. Work closely with scientists from other disciplines, including biochemistry, biological, nuclear physicists, mechanical engineering, electrical engineering, all of those people who are specializing in those areas. They had to come and make all this equipment work and get what they want. Also teach and mentor students in the undergraduate and postgraduate level. Now, the next thing that I'm going to discuss is how do we produce these radioisotopes? Some of the people in this level, there is a problem in terms of understanding what are radioisotope and radiopharmaceuticals. And this is something that I want to allude in terms of understanding the basic concept in terms of this. When we talk about the radioisotope, we are referring to those substances that are used to trace a certain structure in the body. But you need a vehicle which you need to use, which are the radiopharmaceutical, to tag into this radioisotope, so as it takes it to the organ of interest, whereby it's going to emit this radiation to be detected by the detectors, as it's alluded. Where do we find these places? We are using a neutron source, a simple example from NECSA. As you can see now, this is the reactor that is used. Then it's using the source of a neutron, uranium-235. So during the whole process, what this happens, from uranium source, which is a fission process emitting a neutron, you produce a molybdenum-99. This is a typical example of the molybdenum generator that NECSA is producing. Then you come up with technetium metastable 99. So if you look at the structure, how this technetium 99 decay, it follows these routes so as it can go to the background level. And part of this process is you find that 88% is that technetium 99 metastable, which goes straight to this level. And another product that is produced there is iodine-131, which is coming from tellurium-130 using a gamma and the neutron to emit gamma, then you end up with iodine-131. Those are the some of the main isotope which NECSA produces for nuclear medicine application. Then we look at another type of a source, is an ion beam source, which is a cyclone-produced isotope, which is found at Itemba Labs. This is the cyclotron that is found there. And there, they have got the potential of producing iodine-123, not 12332, is 123, which is one of the isotope used in for the production of checking the thyroid gland. So it has got two different routes. The other one is from using this level where you get, instead of xenon, you get cesium-123 that decays to xenon-123, then iodine-123. And when you look at this, you find that this iodine-132 has got a half-life of 13 1.2 hours and the energy of 149 keV. These are the critical part in terms of identifying the type of isotopes that we are producing. And another one, they are not producing this one because it's complex, but you can use a cyclotron to produce a technetium-99 metastable, as NECSA is doing. So for the mere reason of not duplicating the function within the country, then they are not focusing much on this, they focus on the other isotopes. And in nuclear medicine, one of the criteria that it's looked at is you need to choose the isotope which has got a short half-life and which has got an energy enough to penetrate through tissue so as you can be able to detect it using detectors like gamma cameras, so as you can form the image at the end of the day. So another thing is with this short half-life, the clearance from the body itself for this isotope must be reasonable so as when you inject into a patient, within a certain period of time, this type of isotope must have been cleared out of the system for the mere reason to try and reduce the absorbed dose or exposing the patient with a high dose of radiation. That is the concept that is applied. So now, coming to other type of isotope in terms of treatment, as Professor Vangu has indicated some of those. If you look at iodine 131, some of them, they are selected based on either the type of radiation, which is either the gamma source or beta radiation or alpha radiation. And based on these three, as you know, with alphas, if they are embedded deep in the tissue, you won't be able to trace it using the gamma cameras from outside. So now it will be a difficult situation if at all you use the alpha sources. But the beta ones, to a certain extent, some of them, they can penetrate, but they might not reach the detector. So if you look at iodine 131 as a typical example, it's applying two different types of energies. One is a beta source and the gamma. It emits both gammas and betas. So the gamma is the one that will be able to reach the detector, so as you can be able to pick up identify the detector, the radiation where it went. And one of the key things when you look at that, based on the type of radiation, it means to say the selection of this radioisotope is very important, because now that's where now you will be looking at the physicists, the nuclear physicists, to identify, to categorically tell you exactly what kind of radiation you have in the system and the gamma radiation that you are producing. So now, going further, this radioactive material, like at NECSA, they make generators, which this is a typical example of generators. You can see how it goes through the whole process. Once you get into this level, one of the critical part of this thing is to make sure that whatever you are doing, it's tested, and you need to package it properly and make sure that you deliver it to your client, as you can see there. And another thing that I want to mention, firstly, I spoke about production of isotope. Now, the radiopharmaceutical, which is a sort of a compound that binds to this radioactive material. And fortunately enough, within the country, in South Africa, NECSA has done a fantastic job in terms of radiopharmaceuticals, because they've got a special lab that produce that kind of radiopharmaceutical, like MDP for bone microspheres, you name it. So as you can couple it to this radioactive material to take it to the organ of interest, so as you can be able to do the imaging. And when you look at it, this is part of the processes in terms of the where you produce the radiopharmaceuticals. It comes in this form of powder embedded into certain vials. Then you've got another vial whereby it's under vacuum, whereby you take the eluent, you take this vial, you put it into a generator where you suck in the radioactive material into these vials. So as then when you prepare the injection, you take this substance, you mix with the radioactive material so as you can be able to inject into the patient. Those are the basic concept in terms of this. And the main process is this one, whereby you got your radioactive material, your radiopharmaceutical, that is going to bind to a certain tissue there, or cancer tissue. And that is the concept that when you are designing this radioactive material, you are focusing on. And this is one of the key areas. As Professor Vangu was mentioning, there are different types of diseases that can be need to be tested. So now you need to make sure that you are able to understand the chemical reaction between your radioactive material, your radiopharmaceutical, which is going to bind into a certain site of a tissue of interest. So that is the concept that is applied in nuclear medicine, so as we can be able to get what you want. And the process is the quality assurance, which is required, and quality control. For radiopharmaceutical, check for, in terms of a molybdenum generator, they check the molybdenum breakthrough. So what does this mean? Because if you think in terms of the technetium-99, you find that you get some other isotope, which is not technetium-99 metastable, which has got a half-life of 6 hours. But you get also, which is this technetium-99, which has got a half-life of 2.11 times 10 to the power 5 years, and the energy of 249 kilo-electron volts. So now you don't want this to get into the final product that when you do your elution, because this will form a lot of background because it doesn't bind properly, and it will stay in the system for a very long time in the system whilst irradiating the patient. Then also within this generator that they've got what they call alumina sponge. So this is the one whereby when you inject this technetium 99, it adhered into it, so as it stays there. So when you run your sodium chloride, which is a solution, a normal solution, through this, it separates the daughter isotope, which is from the molybdenum 99, with the daughter isotope being technetium 99 metastable, which you need in order for you to mix with the radiopharmaceutical to inject into a patient, so as you can be able to do the scan. Then the next thing that you need to do when you check on this radiopharmaceutical, you have to check the chemical binding. So now, if you take this radiopharmaceutical, you, as I indicated here in this slide, because you have to take this radioactive material, combine it with this radiopharmaceutical, so as it forms, this one will take this radioactive material to the organ of interest, so as you can be able to trace it. So now you must check the chemical, the binding. If this is your activity, which is the radiopharmaceutical, radio isotope binding to the radiopharmaceutical, which is B, then you must have a forward reaction, and there is a forward reaction and a backward reaction. But the forward reaction must be always bigger than the backward reaction. That's where you'll say your chemical binding is good for this particular radioactive material to be injected into the patient to go and tag into the organ that you want to see on your scan. And then the next thing you need to a detection system. So you need to also check your gamma camera sensitivity, the image uniformity, and the image resolution. Because if you don't have this from your detector system, you would not be able to see the images that the physician would like to see in terms of this. So now, the next thing in nuclear medicine, what is critically important is this one. So you need to understand the biokinetics of the radiopharmaceutical in the patient. If you introduce this radioactive material, it gets into the plasma region, whereby it can go to any of these, the skeletal system. So in the first place, it floats into all these different organs. But at the end of the day, it has to come out through either urinary system or fecal system. So now, these are the things. So after injecting this patient, you need to understand what goes on inside the patient. Are these radioactive material going to be cleared on time so as you are left with what is necessary? For example, if you are doing bone scan, it will be on the surface of the cortical surface of the bone, or it goes to the area where the tumor is on the bone itself, or the fracture where the fracture is. Or if it's in the heart, much of the radioactive material must be confined in the heart, not all over the place, because if there's a high background radiation, you would not be able to identify the image that you would like to see. So now, the next thing is, if you look at the concept of radiation imaging and treatment, so the imaging of radioisotope, the radioisotope emitting gamma radiation, this is one of the key things in terms of this one, because now, as I indicated, that you need to know which type of radioisotope you need in order for you to get the picture of this. The gammas will penetrate from deep into the organ, pass through and get into the detector itself. So where it's going to be recorded as interaction within the detector itself. So it forms an image. So that image itself, when you look at it, it's based on what we call linear energy transfer. So now, if you take betas, the linear energy transfer is much shorter as compared to the gammas, whereas the alphas is so small because it will only penetrate about 0.04 millimeters of tissue. So it won't reach the detector. So now, those are the criteria that you need to look into. So now, on the therapeutic side, now, the best way of looking at it, if you do have a combination of radioisotope that has got a gamma, beta, or alpha, that will be the ideal situation, whereby if it emits gammas and betas, and due to the linear energy transfer, or what we call the radiation weighting factor in terms of this, then we will have to look also into what we call a tissue weighting factor, how much it can deposit into this particular tissue. That is one area in terms of that, the treatment. Secondly, in terms of the treatment itself, we are also combining the issue of understanding what we call the sensitivity of the cells. When we talk about the sensitivity of the cells, what do we mean? We mean to say this particular cell, if the cell undergoes cell division within a period of, a normal cell is 24 hours. It's 24 hours. So, sorry about that. So the normal cell, a cell cycle is 24 hours. So now, for cancer cells, most of the cancer cells, the cell cycle is much shorter. That's why the high resistant type of tumor, the cell cycle is much longer. So now, based on the results that you get from the checking which type of cancer it is, it will talk to you in terms of how you treat cancer, in terms of saying, if the cells is much sensitive to radiation, it means to say the life cycle is much shorter. When radiation breaks the chromosomes, the chromosomes do not have enough time to recover. That's why now the cell will die, depending on the dose that you are delivering into these particular cells. So that understanding itself, it has to be related to the type of radiation, what type of radiation you are using. So now, these are the basic concept. You take your radioactive material, you measure into this thing when you want to, how much dose you want, you measure there, and you can see the spectrum and the counts. And then you put your patient into this SPECT CT. So the SPECT CT, it's one of the equipment that it's used in nuclear medicine. So SPECT, it stands to single photon emission computerized tomography. The other one, CT, is computerized tomography. So it's a combination of X-rays and radiopharmaceutical, taking the image at the same time, so as you can be able to look at that particular area. The CT look at the anatomy of the structure, whilst the SPECT look at the physiology of the structure. So you can see now some of those ones are appearing like that, and some of the equipments, as Professor Vangu has alluded, when you look at them, they look similar, but the concept behind inside these are almost similar, more especially the CT on the one that was showing you, where you've got a gantry with a series of detector detecting the radiation. Now, in conclusion, in nuclear medicine is based on is a specialized biomedical physics, which is both for diagnostic and therapeutic. A combination of specialists are important in conceptualization, design, development, test, commission, and final product. What does this mean? If you look at the gamma cameras, you need somebody who would conceptualize it, do research, make sure that the system is working and it can do what you want to do, and you take it to the mechanical engineers, you bring in the electrical engineers to put all the concept of mechanical engineering, the concept of electrical engineering, whereby you are putting this system to work using all the knowledge from the science level, and also bring in the concept of computation, machine learning, which is a fourth industrial revolution. That's where it comes in. And based on all these things, also, we are looking at, in terms of radiopharmaceuticals, all the combination of the nuclear physicist, understanding the nuclear physics or the radioisotope production, understand how the biodistribution of this, how the radiation interacts with the matters, and how to do counting, survey, and all this. It's a combination of everything. And in this case, when you look at nuclear medicine, it's a very good platform for now for us to be able to introduce this section because it covers the whole range: chemical engineering, computation, electrical, physicists, mathematics, all this, they form part of nuclear medicine in terms of the radiation production, the radiopharmaceutical production, the machine that you want to use in order for you to produce all what you need. I think my talk ends here. Thank you.
Oh, thank you, Dr. Mavunda. Excellent presentation. And you certainly, both you and Professor Vangu have certainly whet our appetite to get into the laboratory and to make our individual contributions. Colleagues, let me at this time invite Dr. Coyote and Dr. Minar, who are with us, to join us on the chat for questions and answers. Dr. Coyote and Dr. Minar, if you may join us, you may switch on your webcam. And also Prof Vangu and Dr. Desmond, if you may also switch on your webcam. And there we are. There's Dr. Coyote there, Dr. Rampersadh, the incoming chairman. And to guide us and lead us in terms of questions for the audience, we have a very stable audience of today. Thank you very much. Very dedicated attendance, much appreciated. And we look forward to your input and contributions to the chapter as we grow and develop going further. Any first thoughts, Dr. Coyote, from your side? Any question that you'd like to table? Dr. Coyote is one of our postdoctoral research fellows in this sort of specialist field of radiation biology. Over to you, Dr. Coyote.
Yeah, there is a question here from Kamsha, which goes thus: how can one become biomedical engineer considering they are studying engineering at UJ? I think the question goes that how can one actually become a biomedical engineer in maybe South Africa, for example?
Right. We have an engineering student who would like to specialize or go further in the field of biomedical engineering. Any first thoughts on that, colleagues? Prof Vangu, any first thoughts?
Yeah, I think that Desmond Mavunda actually explained it clearly, where the programs and then how to go through it. So maybe I will leave it to Des, because he indicated actually where the programs are taking place currently in the country. And then so let me then not hijack it and leave it to Des Mavunda.
Desmond, over to you.
Thank you. There are quite a number of institutions in the country. At UJ currently, in terms of biomedical engineering in nuclear medicine, we don't have that specialty, but it can be done in collaboration with other tertiary institutions. And if you look at Wits University, they already have the biomedical engineering, whereby a student we can take, I think we link up with other, because we have got this collaboration amongst universities. Thank you.
Oh, thank you. Yeah, University of Witwatersrand has a formal department, biomedical engineering. Also University of Stellenbosch, and I think also University of Pretoria. And I think, Dr. Mavunda, we challenge you to get UJ's first biomedical engineering department established and operational. Thank you.
Yeah, I think there is this question may be a little bit technical, especially for radionuclide production that have short half-lives. So how do you export those products out of South Africa? Because I noticed some of the half-life ranges between 4 and 6 hours. You have to export them, and then the challenges with clearing at the customs office. So how do you overcome these challenges?
Dr. Rampersadh, that's for you.
No, thank you, Chair. And I think that's actually a very question. Obviously, what is how NECSA deals with this issue is we actually had to create a logistics company, a specialist logistics company that actually is able to, from production through to the doctor, to the medical institution, be able to get our radioisotopes through to them in a reasonable period. So effectively, we also had to deal with, remember, when you're moving radioisotopes between countries, there are regulatory approvals between the two countries. So we actually have regulatory specialists who actually then start to engage with the regulatory authorities in the different countries to ensure all of the boxes are ticked. So this will result in, firstly, that when obviously a radioisotope, a medical isotope arrives in a particular country, it's not going to be held back at customs. It's not going to be held back in terms of delivery. It will not held back unfairly. So, I can put it that way. And before we even start to decide to export any medical isotope, and I think we supply over 50 countries, I think, around the world. So we actually are very, very tight with our logistics arrangement. So as soon as it comes off production, it has met all of the approvals within the system, we then obviously have a logistics company that will then get this as quickly as possible through to the airport. All the clearances are done in advance, I think, and of course to ensure everything is in order. And then of course it's moved to the next country. So yes, it is actually, we actually had to create a separate entity that only specializes in moving this around the world for us. Thank you.
Oh, thank you.
If I may add something there, because Dr.
Can I come in? Can I come in also?
Yes, Prof Vangu first, then Dr. Mavunda. Prof Vangu.
Yeah, just one thing that Pradish was so kind, didn't want to go to details. It's because Dr. Coyote talked about specifically 6 hours. I understand he's looking at all these PET trace like the fluorine. So just to add one thing, that like Nigeria, where you are now, it's a big country. If you have to live, even if you do it within the country, somebody that if the production is done in Lagos and then you need to take them by flight to go to Abuja, the capital, what tradition the team they do, they manufacture them. If you go back to the physics that Dr. Mavunda explained, to the point that they do many half-lives, so that when it reaches you there in Abuja, it's going to be within what was prepared for the dose for that day. So even if it's still in the same country, you have to know that the physics is behind everything to make sure that when they deliver it, the dose will gonna be in the half-life that will allow you to use them. So just a simple comment I wanted to put. Thank you.
No, thank you. Dr. Mavunda, if you may follow through.
Yes, thank you. That problem is solved by, you must remember, when they produce a generator, a typical example with a half-life of 6 hours of technetium-99. We have got a parent isotope, which is molybdenum-99. It has got a half-life of 6 days. So, and at the same time, if you look at that one, as you ship it into, you take it by flight, it will reach the destination before it gets into half of molybdenum-99, because that is the key issue there. So now, as molybdenum decay, it produces technetium-99, which is the one that you are going to elute a specific activity on that particular day. So that is taken care of because of the parent isotope, which is molybdenum-99 in your generator. And other isotope like iodine-131, it has got a half-life of 8 days. So it's not a problem. What they do, they calculate based on the requirement of the client to say, this is what we are putting into this capsule so as it reach you as soon as possible before it reaches its half-life. Thank you.
Thank you very much. Excellent.
But you can see that we can talk and talk. We'll never stop with this because these
Very
are
interesting.
very complicated things that Pradish and the team, they do there. It is really, now, for example, you take the point that Dr. Mavunda now say, okay, iodine 131 is not a problem, 8 days, so we can do it. But it's not only the half-life. We have also what you call shelf life. So how long can you still keep it before you administer it to an individual? So this product that they manufacture that we use in nuclear medicine are just fantastic. And then patients, sometimes they do not understand when we say to them, you must be on time, because if we don't use it, it's still there, but it's not active anymore. Everything is gone. So in terms of health economics, it's something that need education of the health provider, education of the patient, education of everybody. Otherwise, we'll put most of the stuff to waste. Thank you.
No, thank you. Thank you, Prof. No, thank you. Very, very good question and good comments and lots of work to be done. And we need lots of hands to come on board. And I think this is the reason of the chapter, to whet the appetite of the youngsters to come forward and join these exciting careers going forward. Excellent. I don't have any more questions on the chat. Sorry? Who was that? Minx Cummings?
Yeah, I said there is no more question here.
Oh, okay. Okay, was that Dr. Coyote? All right. No, thank you, colleagues. And I think certainly an exciting field, a lot of thought, and well done to our contributors. And we want to wish Dr. Rampersadh well on his journey as leader of the chapter, to gather all of us around the table and to start giving us the charter forward. We would like to see the chapter accelerate and produce short learning programs, continuous professional development programs, and to invite the greater audience of the medical and engineering faculties to come forward and to participate, to possibly re-energize their existing careers or to redefine their existing careers, and to find opportunity in serving society going forward. Colleagues, may I bring your attention to the chat, whereby we have the links in terms of the next steps. The proceedings of today would be available on the SAIEE TV channel as the YouTube presentation, and you could download it and use it in your own workings. There's also the chat in terms of the academy itself, the training academy, and the preparation of the short learning programs and the courses going forward. Let me at this stage hand you over back to Minx, our boss, our editor at the What Now, to introduce the poll that she would like to talk about. Over to you, Minx.
Thank you very much, Prof. Ladies and gentlemen, firstly, I'd just like to thank all our panelists and presenters. It was really, really informative. I'm going to launch a poll now. It will just for a few seconds. I would just like you to please just click on there, your whatever answer, how you've learned about this webinar. We're trying to, like I mentioned, we try to sharpen our pencils in how we communicate with our members and our attendees for webinars. I'd just like to know that we're doing the right thing. And you will also see in the chat box, as we mentioned before, how you want to join this chapter. You just send an email to biomedical engineering at saiee.org.za, or register a profile on the SAIE website. You don't need to be a member to register a profile. In that way, you will receive our Every second day, Tuesdays and Thursdays, we circulate the Chronicle and the Academy News every second Thursday of the month, and you will receive that communication, and we'll keep you updated to up and coming meetings and webinars of the Biomedical Engineering Chapter. Thank you. I'm going to close the poll now, and then I'll hand you back to Pat.
Thank you. Thank you, Minx. And thank you, colleagues. I think we've come to the point now where we'd like to say thank you, appreciate it, and we'd like to close the webinar. And we'll then hear further from the chairman and the members going forward. All right. So, colleagues, can we exit? Thank you very much. And let us say goodbye to all of you. Thank you and bye-bye.
Thank you.
Thank you.
Bye-bye.
Thanks. Bye-bye.
Thank you. Bye-bye.